And now we get to the research part of our presentation. I'd like to invite Dr. Schneider up to introduce our speakers.
All right, now for the really fascinating part, the research update. It's my honor to introduce our two distinguished speakers this evening. Dr. Maahs thought that might make him seem a little bit too old, but I think you are absolutely. We have distinguished guests. Dr. David Maahs holds both an MD and a PhD degree. He's professor of pediatrics and division chief of pediatric endocrinology at Stanford. He came to Stanford just about 1 year ago from the Barbara Davis Center in Denver, Colorado. Dr. Maahs' research interest is to improve care and prevent complications in people with type 1. His research focuses on cardiovascular and kidney complications in young adults with type 1. And he's also worked to develop innovative behavioral interventions for adolescents. He's co-authored the 12th and 13th editions of the Pink Panther Understanding Diabetes books. And since improved glucose control is the best proven method to prevent type 1 complications, his research has increasingly focused on the development of artificial pancreas, probably not coincidentally, because he also has joined Dr. Buckingham at Stanford. Dr. Steve Gitelman holds the Mary Olney Distinguished Professorship of Pediatric Diabetes and Clinical Research. He serves as the director of the Pediatric Diabetes Program at UCSF Benioff Children's Hospital and has taken amazing care of my daughter for many, many years. Dr. Gitelman's clinical research, he aims to better understand the cause for immune-mediated destruction of insulin-producing beta cells, as well as to find safe and effective means to alter the natural course of diabetes. He serves as the UCSF Center Director for the National Institutes of Health-funded consortium TrialNet, which we're going to hear about tonight, and is also an investigator in the Immune Tolerance Network, for which he oversees clinical trials to preserve beta cell function. So please join me in welcoming both Dr. Maahs and Dr. Gitelman. All right, David.
All right, thank you very much for the kind introduction. And we will get started. So let's see, is this way? That one?
Should be this one. Uh-oh.
Advanced slide?
Oh, there you go.
Oops, okay, too excited. All right, so I was asked to speak about a few things in particular, but I think the context of this is why do we need JDRF research? And I'm going to go over a little bit of the current clinical context, a little bit of recent data on where we're at with hemoglobin A1C, severe hypoglycemia, prevention of DKA, and then some of the data on mortality, and also in the context of what we're doing to try to improve some of these outcomes. Then I'm going to show a slide on the stages of type 1 diabetes, which Dr. Gitelman then will also go over as well. This is a new concept in the last couple of years that JDRF was a big part of, and we'll go over that. And then both Dr. Gitelman and I spoke at the ADA in a session that in part was about the TrialNet oral insulin trial, so we'll go over that. And then also Dr. Gitelman's research, which he'll show us. So you're getting part of what was presented at the ADA here. And then also talk a little about what's needed and some of the challenges, and then loop back to that stages of type 1 care and talk about the continuous care paradigm and how we can look at that. So this is a slide that comes from the T1D exchange, and what it shows us is that if we look at the age on the bottom, and this is in about 16,000 people with type 1 diabetes in the US, and then we look at the axis with the A1C, and we see that the goals for A1C are 7.5 for children up to 18 years of age, and then 7 for adults. And you can see that we're just not doing as well as we should be doing, and we're much too high in pediatrics. So we've got a lot of work to do. Now you can look at the next slide and say it's either encouraging when you compare our data to Germany and Austria that they've figured out how to do better, but also it's a little bit discouraging that here in the US that we're running about 1% higher than our colleagues in Germany and Austria. So these are data that we've just presented at the American Diabetes Association, and it's really leading us to ask some questions internally in the US about what can we be doing better, what can we learn from some of our colleagues. And there's probably many reasons for this, but just to highlight the point that we're trying to figure out how can we do this better, but also the need for prevention and for cure. And again, we really need to delay diabetes. We need to prevent it. We have too much severe hypoglycemia. This is a great fear of all of us in the room. We have too much diabetic ketoacidosis in pediatrics. In this study, between 5 and 7% of the pediatric patients were having DKA every year, and that's just too much. Unfortunately, and I hate to talk about this in this audience, but the complications are still a problem. We don't see it in pediatrics, but this is why we're so focused on better control. That cardiovascular disease continues to be the leading cause of death in type 1. Eye and kidney disease, which we all worry about, continue to cause problems for people with type 1. And lifespan is still shorter than we would like it to be. Now, I don't want to be too depressing with these data because it's getting much better, and those data are in adults and not in our patients now who are getting diagnosed. This is improving rapidly, but to emphasize that we need to continue the work that we're doing to make this better. And then the last point is the burden of care on people with type 1 is tremendous, and on their families. And we need to keep working to reduce the amount of work that people have to do to care for type 1. People worry about their children, their loved ones now. They're worried about the future. And there's also tremendous financial burdens on people, and it goes on and on. So we need to continue to improve. This is a picture it's a cartoon from a book called Bittersweet, which is a case history from the Joslin Center. And this was a patient who was followed there for 30, 40 years, and he was a cartoonist. And this was one of the pictures. This is what diabetes was like for him in the 1940s and 50s. He had basically, it was a chemistry experiment to try to figure out maybe what your sugar was in your urine. That awful thing he's injecting insulin with. This speaks to me. I had a grandfather with type 2 diabetes, and I remember him sharpening his needles as a child. Thank goodness we're not in that world anymore, and things have improved dramatically. We're making great progress with diabetes technology. If you look at that first slide, that one didn't do well commercially. The second slide, a talk with Peter Chase and Bruce Buckingham. They remember when patients were excited to wear a pump like that in the middle. And now we're in a place where we've got things like the 670G from Medtronic. We've got companies here in the area like Bigfoot who are developing artificial pancreas systems that are in clinical trials. Others like Insulin. There's many, many companies who are working in this space, and these are now available. And JDRF has been the leading force to get these to where they are in the last 10 years. So JDRF has done a tremendous amount of work, and these are going to continue to improve and continue to have an impact to make lives better for our patients. Now, this was the slide that I want to go over, and Dr. Gitelman will go over it again. This is a new way of conceiving of type 1 diabetes as different stages. And if we start on the side, let me see if the pointer works, there it is. We all have a different genetic risk for type 1 diabetes. And then at some point, something happens that the immune system is activated. And at that point, then there's destruction of the beta cells, and there's fewer and fewer beta cells. And at that point, we can measure things called antibodies, or a sign that the immune system is reacting against the body. At a point then, we get down here, which we're now calling stage 1, where you have 2 or more antibodies. And this is now being called the start of type 1 diabetes. You still have normal blood sugars at this point, but we know with those antibodies being positive that you're going to progress on highly likely eventually to then clinical disease. The stage 2 is when you then start having abnormal blood sugars with abnormal antibodies. And then stage 3, where you get to the point where you're symptomatic and have signs of diabetes. And then stage 4, which is called long-standing type 1 diabetes. And so if we look at it again, we have stage 1, there's beta cell autoimmunity, your sugars are normal, you're not symptomatic yet. Stage 2, then you have the autoimmunity, some abnormal sugars, you're not symptomatic yet, so we usually wouldn't pick these type of patients up unless you're in a research study. And then the third stage, then you start becoming symptomatic, the peeing a lot, drinking a lot, losing weight, decreased energy. So what we're talking about is then a continuum, and how can we start to intervene earlier than this stage 3 where we pick up patients now? How can we do something back in stage 2 to prevent progression to stage 3? How can we pick someone up here in stage 1 and prevent them from going on as well? And Dr. Gitelman will talk more about that, and I'll show you data from the oral insulin trial next, where they tried to intervene here at stage 1 when people had positive antibodies and tried to prevent progression on. So TrialNet is a large group that does studies to try to prevent the progression of type 1 diabetes, try to cure it. And the precursor of that was a study called the DPT, and they had a study in which they tried oral insulin, but it did not show a reduction then in the development of type 1 diabetes. But at the end of the study, they looked back at the data and found that in a subset of patients, that oral insulin seemed to be benefiting the progression and preventing the progression of type 1 diabetes. So therefore, they designed this oral insulin study to try to investigate whether giving oral insulin to people with antibodies could delay it in a similar type of population. So just briefly, the design of this study then, it was a 2-arm study. Either you got oral insulin or you got the placebo. We didn't know who was on what. The patients didn't know. The objective was to determine whether the intervention with this pill of oral insulin would prevent or delay the development of type 1. And then the primary outcome was the time from starting the study until development of type 1 diabetes. And then there were multiple other secondary outcomes, which we'll go over in a little bit. So this was really a monumental undertaking. There were 87 different locations across the world. They screened almost 140,000 people to find those who had these antibodies that were positive. Then that was about 3,000, and then different people chose to participate or not. Ended up with 560 patients in this. Also, you'll see that this study took over 10 years to do. So these are very challenging studies to do. The investigators deserve a lot of credit. The participants and their families deserve a lot of credit. This was a big undertaking. All right, so this is my one slide where I've got a p-value. So the biostatistics, I told Karen I would try to limit this, but did have one here. So let me walk through this slide so it's not too complicated. Basically, to get in the study, you had to have antibodies that were positive, at least 2 of them. And there were 2 different classifications. You either had this antibody plus these or this antibody plus these. Then the second characteristic is they examined how much insulin function you still had, how much insulin were you producing. And they categorized you as above or below a threshold. So the bad news about this study, and it was not fun to have to present part of this at the ADA, was that the results were negative when you looked overall at the study. Now, if you looked at this group, though, this one box with this particular type of antibodies, and then actually that they had a little bit less insulin production ability, that there was a positive effect, that oral insulin did delay insulin by 31 months in the people who had the oral insulin pill versus those who did not have the oral insulin pill. So what does that look like? I've got 2 slides with the key take-home messages. So I hope that slide didn't throw you off with all the statistics on it. But again, the question was, can oral insulin delay or prevent type 1? This was very challenging, the time, the effort, the cost. And the findings in this randomized clinical trial, oral insulin did not delay type 1 in the primary group or overall. So these results do not support the use of 7.5 milligrams of oral insulin to prevent type 1. But what about this secondary group? Okay, and that's what Jordan came and asked me after the talk. He said, well, what about that secondary group? So let's look a little bit more at that secondary group. So this was about 10% of the patients who were in the study. And in that group, there was a 31-month delay in the diagnosis of type 1 if you had oral insulin versus not having oral insulin. So that sounds like pretty good news. If you could delay type 1 diabetes by taking a pill for about 2.5 years, that would be a very positive thing. Oral insulin is very safe. It did not have an effect on lowering blood sugar. There was not hypoglycemia problems. And then furthermore, among the people who had taken the pill more than others, there was an even greater effect that was seen. So take-home message 2, it didn't work in the full group, delayed 31 months. In a subset of patients, it worked better if you took it more. Large study is possible. That also is a proof of concept that you can do a big study like this, which is important as we look forward and are trying to find other therapies. And then, very importantly, we need to understand why some respond and why others don't. So some of the next steps, there's another study ongoing called PrePoint. It's testing a much higher dose with the hope that maybe there would be a greater effect with that. That's in progress. Also, we need additional studies. There are a lot of samples stored from that study to try to figure out how can we improve future studies, how can we better understand what causes type 1, how can we better understand why some people responded and why others didn't, because we'd like to get to the point where there was a personalized approach that you could tailor it on individual markers, and some people might need some things and others a different approach. And then also another take home is that type 1 is heterogeneous pathophysiology. That's doctor talk for saying not everyone develops type 1 the same way. It's a little bit more complicated than we might once have thought. So what are some next steps? Well, we need to be able to screen better. Again, we talked about there are 140,000 almost screened to find about 3,500 who were positive. Of those, about 2,000 were confirmed, and that went down to 560 who were studied. So we need improvement in how we assay for this. We'd like to do it with less blood. Can we do it lower cost, higher throughput, so easier to screen? And then what do you do about counseling for patients who, if they're told they're positive, or if it's a false positive? So I think these are all considerations. Just briefly, JDRF awarded Daryl Wilson and a basic science team at Stanford and startup company a platform where they are trying to work on this. How can you measure antibodies not only in blood but other fluids, and can you do this safe? Can you do this faster, cheaper, and with smaller samples? So there are many groups trying to work on this. So what else do we need? Well, we need other studies, and Dr. Gitelman will talk about this and some of the exciting work that his team is doing. Do we try one agent at a time? Do we throw the whole kitchen sink at it if they're safe? Ultimately, we'd like that personalized precision medicine approach, but we're not quite there yet. We've got a lot to learn. What can we learn then from other studies, oncology or other autoimmune diseases, how to run these studies better? We need better markers of disease. We need shorter studies. That last study I told you it was 10, 12 years from start to completion. And then a question I have is, will participants in these studies who develop type 1 and then diagnosed early, will they have better outcomes? And I think we need also to be studying that, and that us as healthcare providers, how can we provide better medical care to these people who get diagnosed early, as well as psychosocial support and their quality of life. So also to think about the idea of disease-modifying therapy versus prevention. And going back to that stages slide, I think if we can have incremental advances, we would like the ultimate goal of cure and prevention, but if we can have a bunch of interventions that slow down that progression by 2, 3, 4 years or longer, that would be a tremendous advance to be able to prevent diabetes and for then longer and longer periods, or to delay it from happening. And I think we also need to keep working with the patients we have to try to improve A1Cs, reduce severe hypoglycemia, reduce the burden of disease, improve quality of life, and then how do we prevent this progression to these. Also, I think we should be thinking about how do we combine immunomodulation with other therapies, the artificial pancreas, islet cells. How can we control glucose better and decrease the work that people have to do and give our patients the options and choices to find out what works best for them. So last couple of slides here. I think it's vitally important we continue to investigate the cause of type 1 and be able to delay progression. And how do we synergize these different areas of research so that we can make care better in what we called stage 3 and 4, continue our work in artificial pancreas to get that to more people, islet transplants, improve quality of life, and again, prevention and cure are the ultimate goals. And I think we need to continue getting the message out, not only people in this room, but out into general. The work being done with the special diabetes program is so very important that message gets out there that this is something important and we need to be putting money into this. Just briefly, work with a group called ISPAD, and we've partnered with JDRF, Aaron Kowalski, and their team to help support some international research and also some healthcare providers to be able to come to for example, come to the US for 6 weeks. A couple of people are traveling from India, another from Haiti to go to clinics so that they can learn more about type 1 care and take it back to their centers where they really may not have many resources or expertise. And then just close with the final slide to highlight our Diabetes Research Center, which we just found out today we got funded, so we're very excited about that. Thank you. UCSF also has a Diabetes Research Center, so it's lovely that that the Bay Area has 2 wonderful centers doing research, clinical care. And then our website, both at Packard and at Stanford, where you can go and find out more about research and other opportunities as well. So thank you very much for the opportunity to speak, and Dr. Gitelman will tell us about more that's going on with early intervention. So.
Well, it's a pleasure to be here with you this evening. David did a really nice job of setting me up for my talk. So hopefully we're going to have a little bit of fun here as we go along. This is not me and my wife, by the way. So I'm going to rename the title of my talk, a little bit more technical title. And from what he's told you, hopefully it makes sense when I'm talking about extending stage 3 now. So here's the outline of what I'll cover with you. I'm going to give you some background thoughts on what we call the honeymoon phase, and then talk about 2 different interventions that we're in the midst of, both of which happen to have been funded by JDRF. And then I'll end with some thoughts on where we're going with all this work. Okay, so here's my view of this continuum that David mentioned. And if you think as a clinical trialist, where might you intervene? It would be nice to get in before the clinical diagnosis, so upstream in more of a prevention mode. So we think of this as more the screen and predict and hopefully prevent phase of things. We could come in further downstream after someone has had long-standing diabetes and try and find a way to replace the missing beta cells. And it turns out we've spent a lot of time in this area here, stage 3, in trying to preserve beta cells shortly after someone's been diagnosed with diabetes. So at the end of the talk, hopefully you'll understand why that's such a critical period to understand. So I'll walk through some of the research 101 on honeymoon here. So at the time of diagnosis, we think that most people have somewhere between 15 and 40% of the functional beta cells still present. So that's actually a very helpful remnant. And in the past, when we learned about this and we're taught in medical school, I think the thought was that it's great to have these cells, but you're going to burn through them pretty quickly, and within weeks to months, they'll be gone, and you'll have to fully replace the beta cell. But the longer we study people with type 1 diabetes, the more we realize that that's not quite the case. And so the more recent studies are complicated, but they suggest that beta cell function, at least in some people, can persist for years and sometimes decades. And it's hard for me to summarize all the studies that are starting to show us this. We've learned a lot from this landmark study called the Diabetes Control and Complications Trial. There's a very interesting study of the medalist population. These are people that have had diabetes 50 years or longer that come back year after year to the Joslin Clinic. And a large number of those people, even 50 plus years out, can still make some of their own insulin. There's an unusual couple at UCLA, the Butlers. The husband is an endocrinologist, the wife is a pathologist, and I'm sure they have very scintillating dinner conversations. But their hypothesis was maybe the beta cells, we can still see them years later after diagnosis. And so the pathologist suggested that they just take pancreases of people who happen to die for whatever reason, where the pancreases had been preserved, and look and see if there were beta cells present. And sure enough, even up to 70 years later, there were beta cells defined under the microscope, and they were dividing in many cases. And the more recent consortia that David mentioned, the Type 1 Diabetes Exchange and TrialNet, we've also shown similarly that beta cells can function years later. I think the challenging thing here is, as he mentioned, there's a lot of heterogeneity. It's really hard to determine up front who's going to have a long honeymoon and who's going to have a short honeymoon. This is driven in large part by age. So if you're diagnosed at an older age, you lose those cells more slowly. If you're diagnosed as a toddler, those do tend to disappear pretty quickly. But no matter what age group you pick, there's a great deal of variation. So what we have learned clinically when we study people who have beta cell function is even if you have to use supplemental insulin, your clinical diabetes is much easier to manage. So you have better overall blood sugar control, you have lower hemoglobin A1Cs, less swings in blood sugar, significantly less risk for severe hypoglycemia, and lower risk for complications. So if we can get in and save this remnant of cells, it can really serve people well. So there's one other thought here that falls from the paradigm that we've both shown, and that is it's nice to get in shortly after diagnosis and preserve things, but whatever we learn at that early stage, we can use upstream for prevention, and we could also turn and use it downstream as we try to replace beta cells. So it ends up being a very important stage for informing us about diabetes in many different levels. All right. I don't want to focus too much on the negative, but sometimes we learn a lot from people that have unfortunate outcomes and very short honeymoons. And it just struck me, watching the news, that we have some really celebrated examples of short honeymoons. And certainly the Clintons and the Trumps have not lasted very long, and UK and the EU have not lasted long. Sorry, just a political aside. So back to the topic of hand here of prolonging the honeymoon. So this actually is not a new thought. In fact, in the 80s, there were a series of studies done with broader immunosuppression. One of the drugs that was used in a number of studies was cyclosporin. And it turns out immunosuppression works, but the problem is you have to use it continuously over time. And not everyone responds, and of course there are potential safety issues and toxicities from these drugs. So this field has been on hold for a while as we got up to speed on really what we needed to target for success, and as we got more specific drugs that have come along. So I happened to sit on some of the planning groups for these studies to try and determine what we should use. And I just wanted to give you some sense of how we select drugs for this type of work. So we like to see a benefit, if we can find it, in animal models. And this is one of the real limitations in the field. So it turns out there's one celebrated mouse model called the non-obese diabetic mouse, the NOD mouse, but there really aren't too many other models. So that's been a drawback. As Dr. Maahs mentioned, we can also look at what immune therapies seem to work in other autoimmune diseases and borrow from there and try and use it in type 1 diabetes. We also learn a lot from drugs used in transplant. Believe it or not, transplant has some similarities with autoimmunity. Then we like to use something that we think will have some plausible means of being effective. And what we've learned over the years is, the arm of the immune system that we think is most responsible for destroying the beta cells is T cells. So we like to find drugs that are targeting T cells. Of course, it has to be a reasonably safe drug. Type 1 diabetes is not cancer. It's not a life-threatening issue. Many people are doing very well with their clinical management, so we have to be very careful about how hard we push on the immune system. And then there's this concept of tolerance. And as I mentioned in the past, we can preserve beta cells with continuous immunotherapy, but that's too risky. So we'd like to find a treatment that we could give for a short period of time that fundamentally resets the immune response and then withdraw that drug. So those are the ideal characteristics for what we're looking for. Okay, so I don't want to scare anyone before dinner, but I want to give you a little bit of immunoendocrinology. And it turns out that we all have T cells floating around in our body that have the tendency for autoimmunity. And they have to get turned on by interaction with other cells, and they expand and then head to the target organ of choice. And in the case of diabetes, of course, that's infiltrating the pancreas and destroying the beta cells. So our earlier naive thoughts were, why don't we just try and deplete these cells? Why don't we just bomb them and see if that resets the immune mechanism? It turns out, of course, this is a little bit dangerous to fully deplete these. It's actually very hard to fully deplete them, and the drugs that do this are incredibly powerful. So this has not proven to be a very effective way of doing things. In the course of conducting a number of these studies over the years, what we've learned is there's actually another population of T cells. So they're the destructive cells that I mentioned, but there's the new wonder cell on the block for us is called the regulatory T cell. And so this is like a master policeman that helps keep the destructive T cells in check. And one way to think about this is that in health, you have the right balance between these reactive cells and the regulatory cells. And people destined to develop autoimmunity have an imbalance. They either don't have enough of the Tregs, as we call them, or the signaling to the autoreactive cells is inappropriate. So one of the thoughts is, how can we reset this balance? And we know from work on the other drugs that drugs that are successful in this area basically reset the balance. But one of the thoughts from one of the world-renowned immunologists at UCSF is, why don't we find a way to isolate these cells and grow them up and use the cell as a therapy and bypass the drugs? So Jeff showed that he could do that in mice, which was really exciting. And then we had the opportunity to turn to man. And this is some work funded by JDRF, a lot of this basic work. So we basically found a way to isolate these cells from blood. They have some interesting cell surface markers. We basically developed a recipe for how we grow them over 2 weeks, and we can expand them about 1,000-fold in the course of these 2 weeks. They have some interesting properties that are really characteristic of this type of cell, this Treg. And one thing that was very interesting about this experience is these cells at baseline don't function very well in their regulatory capacity. But after 2 weeks, they look much more like people's cells who don't have autoimmunity. So we can increase the number of cells available, but we can also make a much better functioning cell. So that set the stage for a clinical trial that JDRF sponsored. This was a first in man, what we call a phase 1 study. It was only for adults, And we weren't sure what dose really to start with. We had to extrapolate from animals, and we had a lot of discussions with the FDA about this. So we enrolled the study. The infusions were very well tolerated. And of course, the question is, how did it work? And this is, we basically used 4 different groups at increasing cell doses. So that's what I'm showing here. Each line is a participant in this study. And you'd have to see a lot of these lines to appreciate this. This is how much insulin you can make in response to a stimulus over a 2-year period. And usually when we do this with people without treatments, we see a slow, steady decline over time. By 1 year, you've lost about half. The next year, you're down to 25%. And these curves look very different, particularly in these first 2 cohorts. So that's very exciting. And that set the stage for us moving onto a trial, a phase 2 trial now, where we're just studying children. And they tend to lose beta cells faster. And so if this treatment works, we'll have a much more dramatic distinction between the drug-treated and the untreated patients. We're doing another study called TILT. I didn't come up with these different acronyms. I wish I had. So the TILT study is another study for adults where we're trying to see if we can give something in partnership with the cells to enhance their function. And interleukin-2 is an FDA-approved drug that is used in some other settings, and we're trying at low dose here to try and enhance the function of these cells in vivo. So there's a lot more to come on the Treg front. It's actually being used in other autoimmune diseases. It's also being used in transplant as a way to minimize immunosuppression. So it's really starting to explode. Okay, I'm going to shift gears now and tell you another story. I don't know if you've heard of the drug Gleevec. It's made by Novartis. It's a very interesting drug. It's a first-in-class of a type of drug called a tyrosine kinase inhibitor. It inhibits a very important signaling mechanism in biology. So this was really a first example of precision medicine. What was known was in chronic myelogenous leukemia, a special form of cancer, there can be a break in the chromosomes and a reattachment that forms an unusual kind of fusion protein. And they realized they had to find a drug to suppress that protein. And so that's what Novartis did. It actually targeted some other members of this family as well. So it's a tremendous treatment for this disease. It also works in some other cancers. But what's been noted along the way is that this also can help with autoimmunity. And in fact, when we tried it out in the NOD mouse, it can both prevent and reverse diabetes. It improves your sensitivity to insulin. And interestingly, as we followed advances in other autoimmune diseases, there's an FDA-approved drug in this related class for rheumatoid arthritis. And one of the interesting things, again, from Dr. Bluestone was to try and figure out why this works. And it didn't seem to work by the usual mechanism. So we didn't seem to change the Tregs with this drug. We might have affected how they migrated to the islets, but we also think it had an impact on something called endoplasmic reticulum stress, or ER stress. So let me explain this to you. I think the best way is to use a cartoon here. It turns out that the beta cell is an incredible workhorse, and it makes a tremendous amount of protein, primarily insulin, of course. And in fact, it may make 1 million molecules of insulin per minute to keep up with the challenge after a meal. And what happens when you've lost a lot of those cells is the assembly line starts to get off kilter a little bit, and things start to break down. So here's the more technical scientific way to look at this. Sorry to get back to that here. But so basically, after the onset of diabetes, that 15 to 40% of cells are really taxed. And interestingly, this seems to be what happens in type 2 diabetes by a different mechanism where there's high insulin resistance. So that leads to this process called ER stress. The cell is not folding the insulin appropriately, and when it does that, it's marked for destruction. And one way that Dr. Bluestone and Feroz Papa have shown, again with JDRF funding, is that this seems to help with a protective response to keep the cells from being destroyed. So it's a really novel way to think about treating diabetes that really hadn't been tried before. So We set out with another JDRF-funded trial here to use this drug in a phase 2 trial. This was just for adults. And as I mentioned before, rather than continuous treatment, we tried this for 6 months, trying to mimic what we could do in the mice and to stop it and see what would happen. So here was the outcome that I presented at the National Diabetes meetings this summer. And again, this is very technical, but this is how much insulin your beta cells can make over 1 year. In red is the placebo group, which showed the steady decline. In blue is the drug-treated group, and the curve's very different. And what's particularly interesting is we treated for the 6 months, but from 6 months to 12 months, the curves are starting to separate even further than they were in the first few months. So we now have to follow these groups out to 2 years, but we're rapidly planning from here for a study in children. As you might expect, if you have better beta cell function, you would expect to see that you need to use less supplemental insulin. And so when we ask people how much insulin they use per day, the untreated group steadily increases over the year, but the drug-treated group is less for most of these intervals out to 1 year. Okay, so summarizing, and back to my political statements of the day. We all acknowledge that this is quite a remarkable challenge to treat type 1 diabetes. But I think it's quite remarkable that if you have this undercurrent of beta cell function, you'll do really well. And I think David and I have showed you some early signs that we're on to some promising things with either prevention or a delay of diabetes onset or preserving beta cells shortly after diagnosis. And I think we're gaining some very important insights from these and other studies about what we need to do to settle this problem. And part of this is resetting of that balance of regulatory cells that I showed you. And then I think another part is what can we do to support the beta cell? And that might be Gleevec or it might be other drugs. Let's see what else I have here. Yes. So, and finally, these new onset studies that you hear about, I think they're going to be very important in informing us about what we do on the prevention side and with transplantation. Now, let me get back to this. This slide has served me well for 8 years, but it's a little out of date now. And so I'm going to have to update it. And we're going to make beta cells great again. So I'd like to acknowledge my partners. First at UCSF, I work very closely with Jeff Bluestone, who's a basic scientist and really a tremendous colleague, and some other folks at the center. We do a lot of work with Kevin Harold at Yale, particularly on the regulatory T cell side. And we're happy to take calls from any of you who are interested in these studies or have friends or acquaintances that might have to think about participation in a trial. So I'll stop there.
Great, thank you. Okay, just quick housekeeping. We're going to have dinner served out there. It'll last till about 9 o'clock. So right now we're going to do about 10 minutes of Q&A with our doctors here. So if anyone has any questions, feel free to raise your hand and we'll get some. Okay, we'll get a microphone to you. And if you really want to go get some food, you're welcome to go get some food now. Okay, yeah, we got one in the back there.
I can speak loudly. This is a very self-serving question. So I've had type 1 for 25 years, and I was diagnosed when I was pregnant with my first daughter. Fast forward, I found out recently that my A1C has never been accurate, that it's falsely low. For the last 2 years, my A1C was measured at 4.9. I'm not 4.9, it's probably closer to 7. Have you had anybody else with this situation? Because my endocrinologist has not.
So there was a recent
Come on to that.
there was a recent paper by Roy Beck and Rich Bergenstahl where they looked at that relationship to what's your average glucose to the A1C. And if you look at that in a population of people, there's a very tight correlation. but at any given A1C, say an A1C of 7, your average is around 150, but some people might have an average glucose of 120, and some might be 180. And within an individual, that tracks pretty tightly over time. If you have more rapid red blood cell turnover, which possibly could be going on, then there would be less time for that sugar to attach to your red blood cells. And so you could have a falsely, well, your A1C would be lower than what your average blood sugar would be. And so this is something we're just, I think, starting to understand better. There's also can be some, there was a study that Rich Bergenstahl and Roy Beck did where there were racial differences in that. So that could account for maybe 0.4, 0.5% of a difference. So it's something we're learning more about. If your real A1C or your average sugars were around a 7%, you've been doing a fabulous job, though. 4.4 would be great, but yeah. Well, there's some other markers, that some things like fructosamine. If that doesn't work, you know, I don't know enough now to be, you know, I gave you kind of a general comment on, you know, how there can be some discrepancies, and I think we're going to learn more about this as we have continuous glucose monitoring. And there's also, I think, going to be an effort to how do we take that continuous glucose monitoring, which is a immediate feedback, and you know, the A1C, you come in and people have learned what's a 7, what's an 8, what's a 9, but how does that correlate then with what that average sugar is? And then, you know, specifically what's going on with you, you know, I think there would be people doing research who would be very interested in trying to figure that out. Let's talk.
I was just going to, you know, one comment you made was about this, your onset occurred during pregnancy, and it's interesting that pregnancy is a real big stress test on beta cells. Your insulin resistance goes way up. You need to really crank out a lot more in that third trimester, and it can unmask a tendency towards diabetes. But it's also interesting to try and understand why doesn't diabetes happen more often? So how do pregnant women compensate? So there's a lot of interesting studies because that's a selective expansion of beta cells. And Mike German at our institution has been working on that and trying to understand the factors involved. So that might be one of the clues that we use in trying to solve some of the problems we talked about today.
Thank you.
On this recent JDRF ride, there were a couple of riders who were rather amazing to me. They were 50-ish, like me, but they had been diagnosed fairly recently, like in their mid to late 40s, and so which also somewhat amazed me. And so does that mean that their stage 1 through 3s were particularly elongated, or what do we know about that later onset of type 1?
Yeah, that's a really interesting question as well. Just from observation of the onset of diabetes, you know, we used to think of this as children only, juvenile onset diabetes. And now about 40% of new onset type 1 is known to occur over age 18. We think that these adults are just having a milder process than the children, but it seems to be fundamentally different. So for instance, in some of our drug studies, the adults might not respond at all very well to these immune therapies, but the children can respond very well. So it's just a different process that we have to understand better. I can't tell you today, you know, from taking blood, I can't quite predict from all the immune assays that we can do nowadays really what's different between an adult who's moving towards diabetes versus a child who's moving towards diabetes. So it's a particularly important question, though.
I have a question on behalf of my daughter. She is type 1, but without antibodies. And I was wondering what these stage 3 extension measures might do for someone who's antibody negative.
Yeah, that's another tough one. Nothing but the curveballs here this evening. When we look at people with presumed type 1 that clinically look type 1, maybe 10 to 20% are antibody negative. And at David's former institution, University of Colorado, there's a lot of work in trying to figure out what are these antibodies. And we can now measure 5 different things, but we're probably not done. There are probably other things that we're not quite picking up yet. We happen to be doing a research study where we're looking at people with presumed type 1 antibody negative and comparing them to people that have antibodies. So if you're not already in our study, okay, good, thank you. So we owe you some information. It's taken a while to collect that cohort, but it's something we're very interested in as well.
Yeah, and I showed that slide on ISPAD, and one of the projects with that is supporting a group called Life for a Child, and they support clinics throughout the developing world. The rate of type 1 diabetes in the Horn of Africa seems to be much higher than the rest of Africa and perhaps approaching some places in Europe. So they're doing a study trying to figure out what's going on because they tend to be antibody negative, but they look like they have type 1, but they're antibody negative. So if we can study some of these special populations, perhaps we can get some insight. And the group, I think Aaron Michaels and some other people are working on that. So we've got a lot more we need to learn.
The other part of your question, we haven't traditionally enrolled them in these immune intervention studies. So you have to have an antibody, at least one antibody, to enter the studies. And so, I can't answer your question about how they might respond to immune therapies.
I just want to know the happy version of Gleevec. I think that's the name of it. Like, if everything went perfectly, it became the miracle drug. Can you tell us what is, what's the next step and how does it get to market and big picture timing and things like that?
Yeah.
Going to be optimistic.
Yeah. So it turns out Gleevec's FDA approved. It's been used in thousands of people. It's actually approved for use in children down to age 3. So one way we can get a leg up on this whole timeline is to use drugs that are approved for other purposes and repurpose them for diabetes. So that's a hopeful thought for this approach. Usually what you have to do is have a nice convincing phase 2 study so that people want to invest, which is usually 50 to 100 people. It has a placebo group to compare to the drug treatment group. Then you move into phase 3 studies, which are typically a couple of hundred people. Often you need 2 of those to convince the FDA that you're finding something. So, any of these studies, if this phase 2, I don't really want to tell you the timeline because I pitched the idea to TrialNet back in 2009, and they hemmed and hawed, and finally JDRF picked it up, and now we're just getting our 1-year data. So the trials move slower than we think. But I think as you move into phase 3, things start to pick up steam. And so when we're on the other side of a successful phase 3, I think then we have the hope that it would be approved for an indication in treating type 1. I want to echo one of David's sentiments that I didn't really stress, which is we're going at these trials with single drugs against placebo. And ultimately, we think it's going to be combinations. And so I think we're going to have to take drugs that work by different mechanisms and get some synergy, and that's probably where the home run will come from. And that's the way it works in cancer and asthma and blood pressure control. So it's just hard from a regulatory standpoint to do combination trials up front.
I just wanted to put in a quick plug for this is so important to JDRF, and this is one of the roles that JDRF plays in really intervening and helping with these regulatory processes and taking drugs that are already approved, but helping to make sure that they do come through and that they are approved, and then ultimately that they're covered by insurance for the indication that we need. So I just wanted to put in a quick plug there. Yeah.
Yeah, and just an additional thought on that. So when I originally wrote the trial, we wrote it for a small group of adults just to get a sense for things and then move it into children just because of its widespread use in children. And the FDA felt that we needed to treat a group of adults first and show some prospect of benefit and show that the safety profile was not different in diabetes than in cancer before we could enter children. And, I understand things from the safety perspective. I'm a pediatrician and a father, and but sometimes, that really slows us down. And so, again, JDRF has been very helpful in those conversations with the FDA. What does it take to get a drug into children? And if we'd done a study in adults and it didn't work, we would probably discard it. And yet I told you that there's some drugs that only work in children, so we might miss a success.
Just one other comment on that stages approach and why I think we think it's so important is if you take the example of pediatric cancer, the outcomes are so much better 30 years later, and part of that is because children who had cancer got enrolled in clinical studies to try to figure out what works better or not. With these and that's obviously a much different type of disease than we're talking about with type 1. But can this stages allow us to reconceive how we think about type 1 and have better screening so that we have more patients that we pick up early so that they can go into these studies and we can have more of these and figure out what works and what doesn't work. And so JDRF has really been a big force behind that. And we need to have more tools. And right now, we just don't have many things we can offer people, but we need to keep working at this so that we can answer these questions better.
One last question, please.
I'll make it a two-part question then. The first part is, what's the latest with cultivation of stem cells? That's a part of the equation here. What's your perspective on that? Is that something that continues to go on track and is something that we might be able to even take for granted at some point in the future, that's done and we just have to do this part? That's part one. And then the other part is, what do you think about CRISPR and gene modifying and how that might fit into the future of diabetes cure search?
I'll wade in, and then I'm sure David will have some comments as well. So I think we're pretty close on the stem cell story, but it's tricky because stem cells, there's cells that can grow and divide indefinitely, and then you could push them down certain pathways. So there are a few labs around the world now who are really quite accomplished in making beta cells in a dish before they go into an animal or eventually man. I think the problem with the stem cells, you've got to know that they don't de-differentiate and become an overgrowing mass that would resemble cancer in vivo. I think the other part of this is, this is I'm pretty sure that we can take a cell from a given individual and make stem cells for them and then grow them up and have their own beta cells in an infinite supply. But you knock them off once, and they're going to have the same immune markings, so they're going to be knocked off again. So part of the challenge, it's a two-part challenge. Can we make the beta cells, and then how do we put them in and hide them from the immune system? So we've tried, since the 70s, people have been trying to wrap these things with different inert compounds, and so that's part of the magic. How do you have enough oxygen getting in there? How do you exclude the destructive immune factors that might come up against it? How do you get it vascularized enough and functioning well? So we've been part of this study with ViaCyte and a California Institute of Regenerative Medicine grant, trying to work through this. And ultimately, we think we're probably going to have to use immune therapy with the cells, probably encapsulated in some way. So it kind of gets back to my comment about what we find in new onset could be very helpful in using at that later stage and protecting those cells. Hopefully a mild form of immune therapy. You want to touch the CRISPR?
I don't do that type of research. This is all. I think all of this is very exciting, and I think these new developments. There are probably things out there that we don't yet know about that are going to continue to move the field forward. And we touched on so many different things today, and I think it's really an exciting time to be. Oh, CRISPR. Oh, okay. So it's this gene editing technique where you can kind of take, snip stuff in and take stuff out and put it in, right? It's a little more complicated than that, but that's what I read about.
Yeah. So it's basically a very sophisticated editor function that derives from bacteria, and that has been used as a way to go in and try and selectively rewrite your genetic code. And it's a very powerful technique. There's a lot of concerns that people might use it in the wrong way. Like I want a taller, it starts to sound a little bit like World War II all over again. But I think what's really amenable to this technology are single gene defects. So repairing something like sickle cell anemia or cystic fibrosis are kind of early candidates for use of this technology. So the problem with type 1 is it's 15 plus regions in the genome that are involved here. And one thing we might do is try, if we focused in on what we thought were the most important genes, maybe we modify them so that instead of a high risk collection of genes, you have a lower risk. But it's a much bigger step than these single gene defects. I think where you'll see CRISPR in diabetes, there are some single gene defects that cause diabetes. We call, so some of them are early onset, like neonatal diabetes. Some of them are called MODY, maturity onset diabetes of the young. So I think there's a real opportunity there to reverse diabetes with this technology. But there's a lot of discussion with the FDA and with ethicists, a lot of concern that this genie, in other settings might be misused. It's really hard to know how it's going to roll out clinically. We got to really be careful about it.
And wasn't that technology developed in the Bay Area here?
Yeah,
in part?
Jennifer Dowdy at UC Berkeley is one of the real pioneers, and she actually has a book out that I heard her talking about on the radio recently. She's an excellent speaker, so I'm sure her book's great. But if you have a chance to hear her in an open forum around here, I would go hear her.
All right. Well, I think that concludes this evening. Please join me in thanking our speakers.